There we go. All right, I think we may start now. Good morning, everyone. I'm delighted to see you all here on this balmy July day. Welcome to the Osher Center for Integrative Health Grand Rounds. My name is Andrew Ahn, and I serve as the lead for the new high-tech soft touch initiative here at Osher. This exciting venture delves into a range of fascinating areas from digital health and integrative physiology to complex nonlinear systems. And we're also shining light on some less explored frontiers like acupuncture anatomy, connective tissue, and fascia. And it's within the spirit of exploration that we have the honor of hosting Dr. Neil Theise today. He'll be speaking on a topic that's garnering quite a buzz in both conventional and integrative medicine circles, and that's the role of the interstitium. I know for a fact that you're in for a treat, but before we dive in, let's cover a few housekeeping items. First, we have a Zoom platform for our grand rounds that is quite interactive. It allows us all to see one another, as you can see, and for a handful for you to ask your questions directly during Q&A. But for this to work smoothly, we ask you the following. Please remain on mute during the entire presentation. If you wish to exchange general comments with other attendees during the presentation, please use the chat feature. If you wish to ask the speaker a question, please type in the Q&A feature. I'll be creating these and we'll present them to Dr. Theise in the discussion following the lecture. And if you wish to ask a question directly during the post-presentation Q&A sessions, please use the raise hand feature after the talk has ended. Finally, if you wish to request CMEs, email us at this address and include the following information: your full name, degree, institution, if applicable. All right. Let me stop sharing, and then I'm going to do a quick introduction for Dr. Neil Theise. All right. You'll feel free to share your slides.
Okay. I have to say, I'm particularly delighted that Ellen DeGeneva is using a picture of Andorra as her image for her Zoom. That's quite a nice thing to wake up to this morning. Thank you.
Oh, awesome. All right, let me do a quick intro, Neil, and then I'll hand it over to you. So it's my pleasure to introduce our distinguished speaker, Dr. Neil Theise. Dr. Theise is a professor of pathology at NYU Grossman School of Medicine, actually my alma mater, specializing in liver and transplantation pathology. His groundbreaking research spans from hepatocarcinogenesis to adult stem cell plasticity, and he's been instrumental in developing international standards for chronic hepatitis assessment. Currently, Dr. Theise is at the forefront of defining the anatomy of the human interstitium as a body-wide communication network. And Dr. Theise is also quite the polymath, having bridged conventional medicine with fields like consciousness studies and science-religion dialogue. This broad perspective is beautifully captured in his recent book, Notes on Complexity, A Scientific Theory of Connection, Consciousness, and Being, which earned a 2024 Nautilus Book Award Gold Medal. Please join me in welcoming Dr. Neil Theise, who will be enlightening us on a fascinating role of the interstitium.
Thank you so much to everybody, and particularly to you, Andrew, for inviting me. I hope this is just another step of having lots of fun stuff to do together. So this is NYU from the East River, and one way of thinking about what I'm going to present to you is as if the map of New York City up until recently had all the streets and sidewalks as they linked up to all the hallways in the medical center, but failed to notice that the FDR is running nearby and feeds into that system and feeds off of that system. And it's this kind of scale that we're going to focus on for the talk, because the internal map has been pretty well known for a while. I have nothing to disclose. I wish I had something to disclose, but I don't. And here are, oops, what's going on? Here are some learning objectives for you to consider if you want to go back and look at the slides. We're going to start off with just some basic statements of what's been known about the interstitium. When we first published our paper in 2018, it was talked about a novel interstitium, meaning that we knew that there was an interstitium that had been well described for years, that the fact of an interstitium wasn't something new, but we were seeing something at a different scale than had previously been well recognized. What's been known for decades is that there are two scales of interstitium, one between cells, the intercellular interstitium, and most cells of the body have tight junctions between them so that there is no space between them. They're really tightly held. But there are some cell types that routinely are not have open spaces between them. They're not exclusive in the way they're bound together. And the major ones to think about that we'll see a little bit in the talk are squamous, whether they're lining the skin or any of the crevices of the body. Adipocytes have spaces between them, and most forms of myocytes have spaces between them. And we'll see examples of a lot of these as we move through. And then there's what's been called historically the perivascular interstitium. I kind of think that pericapillary interstitium is a somewhat better word. And this basically is the primary interstitium that people talk about and think about scientifically. And this is the space around capillaries, maybe some other small vessels, but primarily around capillaries, through which nutrients come into a tissue to reach the cells, and through which nutrients from the cells pass into the cardiovascular system for dispersal and elimination. And so most of the time cells are not sitting tightly on the capillary. There's an interstitial space, and that's rich in hyaluronic acid, and we'll come back to that, as well as collagen fibrils. And the standard understanding through all these years is that the interstitium regulates fluid flow, including cell nourishment, as I said, nutrients coming in, and they relate to cell morphogenesis, tissue morphogenesis, regeneration, general cell functioning, and that there's permeability to some kinds of cells, liquids, and solutes. And there's a mechanical aspect, in particular resistance to compression, though I think that we'll come to see there's more to it than that. And in particular, the interstitial fluid is the source of lymph, although historically that's not been terribly well mapped how that pathway goes. And I'm going to show you some new stuff regarding that. So I started getting involved in interstitium research because of these two guys on the left, Petros Benias and David Carlock, who are endoscopists. This is when I was at Beth Israel Medical Center in New York City, not up in Boston, Little Beth Israel. And I was actually in the GI division because they wanted their own liver pathologist within the Department of Medicine. But the result is I was next door to these folks. Some of you may know David Carlock. He was in the Harvard system for quite a long time. And they're what I affectionately refer to as scope jockeys, which apparently is derogatory, David tells me, but I think it's cute. And when there are new types of endoscopes, they're often brought to them to explore how they can be used. And then Becky Wells is a longtime liver colleague of mine, a cell biologist, a molecular biologist, a bioengineer, who, when we saw some of the mechanical properties of what we were discovering, turned to her. And it's actually with her that most of my work has gone forward in terms of the research. And this is the paper that came out, Structure and Distribution of an Unrecognized Interstitium in Human Tissues, an interstitium at a level of scale that was higher than the other things. So these guys had been playing around with this new kind of endoscope, doing probe-based confocal laser endomicroscopy. And the basic mechanism is you inject fluorescein, FITC, a fluorescent dye, into a vein. It circulates very quickly throughout all the fluid compartments of the body. Within seconds, you see everything light up. And it has a little confocal fluorescent microscope at the end. So this version of it, the first version, had a depth of focus of precisely 70 microns. So it could only see 70 1,000ths of a millimeter into the tissue. And the goal was to be able to look at living tissue by endoscopy at the microscopic level. And essentially, this is a money grab. They're trying to get diagnostic microanatomy away from the pathologist, and they can just do it on their own using their scope. I mean, that's seriously what they're hoping for. I'm not worried. But what they would see is, for example, in the esophagus, which is lined by squamous cells, you see that intercellular interstitium between them lighting up with the fluorescein, just as I had described. And then you have a pericapillary interstitium, and you can see that in the digestive tract. These are villi of the small intestine, and you can see that there are tight junctions between the cells. You need a very tight boundary between the inside and outside in the gut. When this becomes leaky, then you have leaky gut syndromes, and that's disease. But normally you don't see any fluorescein in there, but you see plenty within the lamina propria, in the spaces between the capillaries and the lymphangials that you'll see within the connective tissue of the lamina propria. It lights up with Fitzy. So this is the pericapillary or perivascular interstitium as demonstrated in the villi. And you see this throughout the entire digestive tract, depending on what level of scale. Each organ allows the 70 micron depth shows you different things. What they discovered is that when you look in the pancreatic ducts and the biliary and the bile ducts, the extrahepatic bile ducts, you see this kind of thing called a reticular pattern. These dark bands that are about 10 to 20 microns across, filling these complex fluid-filled structures that are bright. And they didn't know what this was. This was 70 microns into the bile duct and the pancreatic duct, which puts you right into the submucosa of those structures because they're so thin. So they came to me and showed this to me, and literally it was a knock on the door. And I said, well, aren't these capillaries? And they said, well, no, if these were capillaries, these would be bright and these would be dark. The spaces are these. And I was flummoxed. I didn't know what to tell them this was. Because if you look at a human bile duct, it's a very simple structure, unlike the rest of the GI tract. You don't have any lamina propria, you don't have a muscularis mucosa, you just go from the mucosal lining straight into the submucosa, and it's this dense layer of connective tissue. And if you do a trichrome stain, staining collagen blue, that's what you see, this dense wall of connective tissue. And we've always known that, because collagen is so stiff that when you cut fixed tissues to make a slide, you're cutting them very thin and you get a chatter artifact. And so these are artifactual cracks within the tissue. And you see them here, and at lower power, you see them here. You also see that there are some vessels with red blood cells, capillaries or venules, or that's probably a venule there, that's a venule there, that might be a capillary or a small arteriole. And this is what we see. And there's nothing that corresponds with this structure. So this was the puzzle they brought to me. And it took a few weeks of pondering. I didn't know what the answer was, but I knew how we would have to get the answer. Somehow between this and the living tissue, we wind up as this on the fixed slide. And so I realized we needed to locate the moment it transitions from one to the other. So we devised this. We looked at 13 patients who we consented who were getting Whipple procedures for pancreatic cancer. So the standard operation is you take out the head of the pancreas and the loop of duodenum that's attached to it, which includes the pancreatic duct and the extrahepatic common bile duct. And so patient was brought into the operating room prior to their Whipple. They were put under anesthesia, given fluorescein, and the scope was put in them, and they could look up into the bile duct and see, in fact, the reticular pattern that they had come to expect. So there it is in the living tissue in the living patient. They then brought the specimen down to the pathology lab where we opened it up, used the scope again, this time on the open specimen, and could identify the reticular pattern was still there. We did a biopsy, put that into a chuck to freeze it to do frozen sections, quick demonstrations of anatomy on the slide. We put the scope on the chuck and could see that the fluorescein was still there and we still had a reticular pattern. And then we cut down through the tissue, making serial slides until we got to a depth of about 70 microns. So we knew we were seeing on the slide what we saw on the scope. And whoops. And on the slide, we took it to a fluorescent scope. and we could see the inverse of the reticular pattern. Now the dark bands were bright green, and the spaces which had been fluid filled and would have been green had this been colorized, were now dark and empty. What this told us is that the fluid has flowed out of the cells, but Phytse is a highly charged molecule, and it's sticking to whatever creates these bands. So we then took this tissue, stained it with first H&E, eventually a trichrome stain. It was the obvious thing to do, and turned it to the traditional view. So the mucosal surface is here, and the submucosa is here, and here you see all those spaces as preserved from the reticular pattern. But when you take this tissue and fix it, the fluid, it dehydrates, the fluid flows out of the cell, it collapses down. And then what we realize is that what we thought had been artifactual cracks within the stiff collagen layer were in fact the remnants of the living tissue's fluid-filled spaces. That through dehydration and fixation have collapsed down. The artifact is the dense wall of collagen. The real are these cracks that are actually the remnants of the fluid-filled spaces in the living tissue. And so this seemed an interesting thing for the bile duct, but kind of, aside from people like me, who's really interested in the bile ducts? Why should the bile duct have this spongy, fluid-filled submucosa? That sort of wasn't clear. And then it seemed a slightly interesting puzzle. But in terms of the interstitium, and I'll come back to say why we could say this is an interstitium, we're talking about a level of scale, an order of magnitude higher than the perivascular interstitium. And whether or not this is actually a fractal network, as I'll show you, no one's done the math yet, but it's suspiciously like one. We saw that there were cells lining these spaces, that you could stain them. We were thinking they would be lined by some kind of endothelial cells, so CD34 and vimentin, which mark human endothelial cells. We stained those, as well as a bunch of other endothelial markers and a few other things that are stem cell related and lymphatic related. And in the frozen tissue, you can see the open spaces, and the fixed tissue, you see them collapse. You can still stain the cells, but now they look like stromal cells that are sort of layered in an array. And the peculiar thing here to note also is that the cells are on one side of the collagen bundle, but not on the other. It's about 50% coverage. This shouldn't happen. It's sort of a dogma that wherever you have fluid in the body interfacing with extracellular matrix, there should be a cell interposed between them. That's true throughout the body, the lymphatics, the cardiovascular system, with the two notable exceptions. The sinusoids of the liver have no basement membrane. There's an open space there, and the glomeruli. And you can ask me about that later. There's some interesting aspects to it. So this became a way of studying these open spaces, but frozen section is a real pain in the neck. To understand the fact that it was negative for all these other markers suggested it wasn't endothelium. It was a very strange kind of endothelium. So we did electron microscopy, and you can see the collagen bundles running this way or cut in cross section, and you see that there is indeed a cell lining one side but not the other. Here are the spaces between them, and when you look closely at the cells, the lining cells, they have none of the ultrastructural features of endothelial cells. They look like a simple fibroblast. So that became another puzzle for us. This is the point when Becky came in to start doing the work, and she was able to do second harmonic generation to prove, in fact, that this stuff was indeed collagen. The autofluorescence in blue is a hallmark of collagen. But we also noticed there are elastin fibers that are autofluorescent, and here we have them stained with an EVG stain. So with elastin fibers running along the collagen bundles and crisscrossing between them, there is an elastic property to the tissue. It's just not floppy, loose collagen. There's actually some mechanical aspects that you can see just from the histology. Now, at the time, I was doing really sort of all pathology, not just GI and liver. And for the next few weeks after we saw the bile duct stuff, I was just getting my clinical specimens and started to notice that when you looked in the submucosa of the colon in a cancer resection, or in the stomach in a cancer or an ulcer resection, you saw the same cracks. So it started occurring to us that perhaps this wasn't a biliary thing, but it was a digestive tract thing. The big breakthrough came when the next week I happened to get a mastectomy specimen from a patient. So the breast had been taken off for cancer, and there's nearly always what's called a skin ellipse, a part of the surface skin that's normal that comes with the mastectomy. And there within the dermis, I saw the same cracks. Um, and in fact, when we stained it, you could see the same cell types lining those structures along the cracks. And so I went back to David and Petrus and said, what happens when you put your endoscope on the skin? Do you see a reticular pattern? And they said, well, it's an endoscope, it only goes inside. Not being an endoscopist, I said, well, why don't we use it on me? So we injected fluorescein into my skin and found a spot where the epidermis was thin enough that we could see into the dermis. And this is actually the published image from the paper. This is the reticular pattern in human dermis. It's my dermis. And this meant that when we see these cracks and see these lining cells, we don't actually have to do the frozen sections of the in vivo microscopy, because this consistently turns into this. And more importantly, these structures and tissue sections predict this in the living tissue, which made my life for research a lot easier. And so that allowed us to collect a whole bunch of tissues on the esophagus, stomach, the entire digestive tract, the urinary bladder, where urologists had been using the same scope and seeing the reticular pattern there, lung, musculoskeletal fascia, tissue around arteries and veins, etc. That wherever we looked at the dense connective tissue, we saw these cracks, and they were lined by the same cell types we saw elsewhere. And so this was a distributed network, it seemed. Now, the question is, to prove that this is interstitium, we had to prove that they are in fact pre-lymphatic. And we could go to clinical specimens to do that. So here is a colon. This is a human colon. Patient had undergone endoscopy, was seen to have a malignant polyp, which was removed at endoscopy. But the standard procedure, if you see a polyp that has a risk of being malignant at endoscopy, you put tattoo pigment into the submucosa. And that allows, when the surgery is done to resect the colon, if it turns out to be cancer, then you know where to look for any residual cancer, and you can confirm they took the right part of the colon out because the tattoo pigment is there. And the tattoo pigment lies in macrophages, which we now can see with this understanding of anatomy, that they're within the interstitial spaces within the submucosa. And we can prove this is pre-lymphatic because every first-year pathologist knows that when you see tattoo pigment in the colon, you will also see it in the lymph nodes draining the colon. So there's a direct pathway between this space here and the lymphatic system. So this could prove that, in fact, this is pre-lymphatic and that this is actually, in fact, interstitium by definition. You can look at cancer movement the same way, and this is ulcerated surface of a stomach with cancer invading down into the submucosa. And when you look closely at the margins, you see the tumor cells are moving through the pre-existing collagen bundles. This is not reactive stroma. This is just pre-existing bland connective tissue that was already present. The tumor cells are marching through it, and when you see it here, you're likely to see it within the lymph nodes. And when you look at dermal invasion of melanoma, you often get melanoma metastases along the skin, and no one's ever really understood why or how that happens, because lymphatics and blood vessels don't go through the dermis, they penetrate down. And so this is a mode for how they spread. And when you look more closely, again, the malignant cells moving through the pre-existing spaces. And when it gets into these spaces, it also travels to the lymph nodes. So this shows that this is, in fact, an interstitium. Becky's particular area of clinical research is biliary atresia, a condition where some babies are born and they're at birth, they start to lose their bile ducts, and she's sort of the world's expert on this disease and has a mouse model for biliary atresia. So is interested to see how this space in the bile ducts might relate to that. And part of the data from she did a lot of staining and analysis for different macromolecules, particularly protoglycans and glycosaminoglycans, including hyaluronic acid. And this is postnatal day 2 of a mouse bile duct. Imagine how tiny that is. Postnatal day 7, and an adult mouse, hyaluronic acid staining red. And you can see there's very little hyaluronic acid in the submucosa. It starts to accumulate in the first week, and this is what the adult looks like. So we realize that hyaluronic acid fills these spaces, it seems, and that might be a useful marker to show the spaces, in fact. And so we've using pigment labeled hyaluronic acid binding protein, which is a physiologic protein in our systems. You can then tag hyaluronic acid wherever it is in tissue sections. It's like immunostaining, except you're not using antibodies, you're using the hyaluronic acid binding protein. And this is a portal tract of a liver with the connective tissue within the portal tract stroma. And we see those characteristic cracks, which I always ignored for most of my career. But now we could stain them and see that, in fact, while they look empty here, it's because routine stains don't stain hyaluronic acid. Here, we're staining the hyaluronic acid, and the white spaces here are the unstained collagen bundles that stain pink here. So, in fact, while these look empty, they look like spaces. They're not empty spaces. They're filled with hyaluronic acid. And wherever you have connective tissue in the body, it turns out they are filled with hyaluronic acid. So teaming up with one of my junior staff, by this time I had moved to NYU, this was a few years ago, we decided to look at human tissues using hyaluronic acid staining. And I think Odisei was at Harvard too, so some of you may know him as well. So this paper came out a while ago, and what we did was we looked at resections of colon, patients who had colon cancer and were getting colectomy specimens, but in which there was a good stretch of normal colon, and looking at skin where there were tumor resections or amputations because of injury and you had normal skin. And we were able to stain those for hyaluronic acid binding protein. And so here's an example of colon. This is the mucosal surface. This is the lamina propria. This would be the area of the pericapillary interstitium in the GI tract, coming down through the muscularis mucosae into the submucosa. Here we're stepping back. This is a lower power view, so you're getting almost a full thickness of the wall, and then you get into the muscularis propria, the thick muscle layer that's responsible for peristalsis, and then down from there, here's the muscularis propria again, and coming down into the mesentery. And when you stain for hyaluronic acid, in fact, you see that there's complete continuity across these structures. These are not barrier structures. They have openings all through them. So going from the lamina propria through the muscularis mucosae into the submucosa, through the muscularis propria, around myocytes, around bundles of myocytes, and the neurovascular bundles that bring vessels and nerves in and out of the colon wall. All of that is stainable with hyaluronic acid, for hyaluronic acid, and down into the mesentery. So across tissue layers within the colon, but also into the adjacent mesentery, which is now thought of as its own separate organ. So across organ boundaries here. We could also look at those tattoo pigment particles, and a good example of the sort of thing that if you don't think to ask, you don't see it. Not only do you see the pigment particles within macrophages, but you also see free-floating pigment that I kind of ignored in our first study of tracking them. And you can see the pigment molecule particles coming down through the interstitium into the mesenteric fascia. And Doug Allison was a resident at the time who had the odious task of measuring the sizes of these particles. He measured so many that our p-values are the best p-values I've ever had in a paper, 10 to the minus 44th over here. And you can see that depending on how far down through the layer, the particles get smaller and smaller, suggesting a mechanical aspect of fluid flow through these spaces. Think of how in a river, rocks will go so far downstream, sand will go further, silt will go the furthest. And so this implies that there's particle movement through these spaces, and the size of the particles may be filtered by the sieve that's created by hyaluronic acid, because hyaluronic acid creates these webs of macromolecules that have a high water holding capacity. And so potentially they could be a mechanical filter. We had two specimens of skin that had tattoos in them, cosmetic tattoos, and you see the same macrophages within the cracks of the dermis, but you also see free particles, and those move through the papillary dermis into the reticular dermis and down into the subcutaneous fascia, the subcutis. And in fact, now we went back to this tissue and stained it for hyaluronic acid. And here, once again, you see between the squamous lining cells, there also, that intercellular fascia is filled with hyaluronic acid, and in continuity across the basement membrane into the papillary dermis, the reticular dermis, down into the subcutaneous fascia. And in further work now, we're preparing for publication, it goes all the way down through the musculoskeletal fascia, all the way down to the periosteum. So the entire thickness from skin to bone is one single continuous pathway. I've already showed you this. Something to note is that between the lumen of the GI tract and the hyaluronic acid filled interstitium is just a single lining cell. And in the skin, it's not even a single lining cell. And so where does the microbiome hang out? In the skin, it hangs out here in the stratum corneum. So there's no barrier of entry between the microbiome that sits here and the interstitial spaces. Even if microbiome signaling is through vascular structures, which is a hand-waving idea no one has any really good data for, it first has to go through the interstitium. Same in the GI tract. And when you have leaky gut, you have distorted microbiome signaling. That's because the interstitium is now open. So this raises the possibility of the interstitium as a primary path of microbiome signaling. But additionally, the connective tissue around every artery and vein has interstitial spaces that are filled with hyaluronic acid, and the perineurium around every nerve, the same thing. And these structures are continuous with the structures of all the tissues they pass through. So the interstitium of the adventitia and the interstitium of the perineurium across the entire cardiovascular tree and the peripheral nervous system is a continuous network that transcends organ boundaries, and that's what allows this to become a body-wide signaling network. How much are we talking about here? It's estimated that interstitial fluid is about a quarter of the fluid volume of the body. The extracellular fluid is about a third. Most of it is interstitial fluid. That means that, and the cardiovascular system, about 7%. So the interstitial fluid volume is about 3 to 4 times the fluid volume of the cardiovascular system. It looks tiny under the microscope. It's in fact vast. And now we've developed this staining where we've got D240 for staining lymphatic endothelium, CD34 for capillary endothelium in magenta, and the hyaluronic acid. And you can see in the tissues of the body, this is the entire fluid network that we're talking about. Blood comes in, fluid flows into the interstitial spaces around the capillary through the fibrovascular, the fibrous network of interstitial spaces and into the open mouths of the lymphatics. This is where interstitial fluid becomes lymph.
Neil, yeah, we're at the 30-minute mark, just to let you know.
Perfect. We're on time. So I'll just show you a couple of things where, again, wending its way to publication. We've looked at the interstitium of the breast, and sure enough, the lobules and the connective tissue of the human female breast as a whole is a huge network of hyaluronic acid filled spaces. And when we do the triple stain, you can see the relationship of the lymphatics. There's an open mouth in the breast, arteries, veins and venules, and the hyaluronic acid filled spaces within the stroma. And what's really cool is, if you remember, those of you who went to medical school and learned about the single cell filing of lobular carcinoma of the breast cells, line up, and it's never really been understood why. It's because they're marching through these spaces, like I showed you with the stomach and the melanoma cancers. And here we've got the first picture. I'm hoping this winds up a cover of breast cancer marching into the open mouth of the lymphatic from the interstitial. So this is a process of cancer spread. The pancreas we've been looking at, low power view, you see the pancreatic ducts, just like the bile duct is surrounded by connective tissue. Here, this is collagen staining red with a serious red stain, and you see all those little cracks between the collagen bundles. They are filled with hyaluronic acid, and that's in continuity with the structures of the pancreatic acini. And there are little magenta positive CD34 capillaries here, here, and here, and here. So this is the pericapillary interstitium within the acini. The pancreatic islets, you see the pericapillary interstitium there as well as between some of the cells, and that's in continuity with the rest of the pancreas. And when you look at the arteries and veins and lipocytes of the pancreas, continuity again. And here you have the intercellular spaces of the lipocytes. And here's a nerve surrounded and infiltrated by hyaluronic filled interstitial spaces. So again, these connective tissue spaces around all the veins, around all the arteries, are in continuity with the tissue and with the entire cardiovascular system. And it's the same for the nerve. They're in continuity with the tissue through which they're passing, as well as out along the entire nervous system. Kidney gives you a nice view too. This is the low power view of a kidney from capsule. This is all human, to pelvis. And you see at low power the hyaluronic acid as a web filling all these structures. This gives you an idea of how it could be so large, even though they're so tiny. Glomeruli do not have interstitium. That's an interesting segregated compartment. Here's the connective tissue around the vessels, around all the tubules, around the adventitia of the arteries, etc., like I showed you before. So we're doing more extensive studies of this in the liver, all the components of the luminal GI tract from one to the other. I've shown you a touch of pancreas. We've got lung in preparation, heart, interesting things about the heart as a two fluid pumping system, not just blood, but interstitial fluid, if someone wants to ask me about that. We're prepping the paper for the entire human gynecologic tract, all one single system, down to the pelvic floor, skin all the way through to the periosteum. And the central nervous system is not excluded from this. And it's harder to demonstrate this in tissue sections, but I've co-authored some papers on the people who do lymphatics of the central nervous system, particularly in terms of Alzheimer's, think this may be the drainage pathway along the vessels and nerves coming out of the skull. So what does this look like three-dimensionally? It's really hard to recognize, but I'll give you how I think of it. Start off with something you can imagine in your minds pretty well, the entire cardiovascular system, from the heart, all the arteries coming out, down to the capillaries, and then coming back through the venous structures. That single tree is ensheathed in connective tissue, all of which contains these interstitial spaces. Now take the central and peripheral nervous system, which is also ensheathed in connective tissue, which also has these spaces, and interweave these two structures. It's already too complicated to imagine, but you get the general idea. Now take all the visceral organs, their capsules and all the connective tissue within them, into the mesenteric fascia. All of that is a single structure, and nerves and arteries and veins are interpenetrating through all of this. All of that is interconnected. Now add what we typically call fascia in the allopathic community, the musculoskeletal fascia, and add that in, and then layer the entire thing with the entire dermis. And that's what your interstitium of the human body looks like. It's a vast network that's very complicated three-dimensionally. Which way things are moving, fluid flow, depends on which tissues are moving or still, episodically or continually. That's also a very complex thing. It's hard to know which direction the tissue might be flowing at any given time. General implications. We suggest that there is a body-wide network of fluid-filled interstitial spaces that has significant implications for molecular signaling, and the hyaluronic acid, because it's also highly charged, probably is buffering not only in terms of size of particles and molecules, but based on their charge. Some can get through, some can't. Cell trafficking. I've already shown you tumor, bacterial infections can spread this way, and certainly cells of the immune system. I could talk about that if you want to ask me. Microbiome signaling, as I've suggested, and the spread of malignant and infectious disease. In terms of this community, these are sort of the speculations that I'm playing with and have spoken to, and some of this is turning into active research. Anatomic cellular aspects of acupuncture points and meridian. It seems a no-brainer that this could be related to that. And in fact, in China, that first paper has been cited 400 times. About 10% of it is from China, from energy practitioners or acupuncture practitioners saying, oh, this is what we've been talking about. So they see this anatomy and recognize it as something they're familiar with. But if you look at the work of Hélène Langevin, many of you have probably seen this diagram from a review article she published. What is this here except the interstitium I've shown you actual pictures of, with the cells that are lining that? So there's certainly things to open up here for exploring acupuncture and meridians and acupoints. Collagen is a piezo crystal when it's stacked up thickly enough. How thick? The size of the collagen in fascial planes. And so creating piezoelectricity means any movement of the collagen is going to generate electrical current, or any electrical current, like through the nerves, is going to generate kinetic energy of motion of the collagen. And so there's a low-level electrical charged current moving through the tissue because of the hyaluronic acid filtering, but the collagen itself is piezoelectric. So there's electrical signaling potentially happening here that's independent of the nervous system. And again, when I talk to practitioners, and I started doing Tai Chi to actually try to have a more experiential aspect of this, is this what we're talking about when we're talking about Qi, about prana? And if you have electrical currents through this very complicated 3D space, and how that changes over time, so 4 dimensions is the architecture of the electrical field generated by the fascia / interstitium network, creating some larger scale stable structure. Is that one way to think of what the chakras are? And then all of these things are obviously going to have effects for body-wide signaling across all scales, whether it's molecular, whether it's quantum level, electromagnetic, molecular, cellular, or the mechanical properties of the larger scale structures. These are all the people who have contributed to everything I've shown you so far. And these are the take-home points. I'm not going to leave it here because I'll make you a bet. One of you will ask a question that will be on this slide, but so we'll be talking about it. And then I'll just finish with this shameless self-promotion for my book. The paperback is coming out, and it has this big gold seal, which I'm very excited about. That was bucket list. And it's been translated into Chinese too, so you can buy it in its Chinese version, only slightly censored. And that's it.
Awesome. Thank you so much, Neil, for an awesome talk, presentation. For the audience, please submit your questions to the Q&A tab, and I could sort of ask Neil these questions. And in the meantime, maybe just a very simple question. Why do you think the interstitium has been ignored for so long, Neil? Is it just simply a matter of just the way the tissue has been prepared?
Well, yeah, so ignored by who would be the first question.
Yeah.
So when we published our paper, Fascia World, which I would include osteopaths, Rolfers, craniosacral people, movement people, they were really upset and angry because to them this was not new. Osteopaths in particular could point to a literature where they were talking about fluid within these spaces for 60 or 70 years. And in fact, I have a Rolfer who I have Ehlers-Danlos syndrome, so I need a lot of work. And And she would say, well, there's fluid in your fascia. And I'd say, no, there's not. And she'd say, yes, there is. I can feel it. And I'd say, no, there's not. I can show you on a slide. There's no fluid there. And then I saw this and realized, oh, we had it wrong. And that fascia slide in our original paper was because of her. I wanted to sort of own up to that. I was in China for liver collaborative work, but when the paper came out, I was asked to give a grand rounds there. And one of the doctors in the room, who was a liver doctor who I knew, also turned out, I didn't realize, high level in the Chinese version of sort of the NIH for traditional Chinese medicine. And as such, he got the first question. And he asked me how people had responded to the work. And I said, well, there are a lot of people who were angry because we had ignored what they'd been talking about. Although once I got to know that community, I came to understand the reason I ignored it is because it's not searchable easily in the medical literature in PubMed, because they haven't been allowed to publish in traditional allopathic scientific biomedical journals. And so they publish in books and they give talks. And so I didn't have access to those. So I said they were angry, but we seem to have accommodated. And he laughed and he said, you know, I said, they've been talking about it for 60 or 70 years. And he laughed and said, yes, and we've been speaking about it for 4,000, which was my first understanding that, oh, there's something about this anatomy. This is a metaphor I think does work. I'm careful with talking about interstitial metaphorically, but the anatomy seems to be an interstitial communication pathway across cultures. And when I've spoken to Tibetan practitioners and their methods of pulse diagnosis, yes, those are the fluid pathways that we're experiencing. As another example, people doing Ayurvedic medicine, people doing energy healing of different practices, they all sort of recognize when I show these images that this is what they've been interacting with and experiencing.
That's amazing. Yeah. It'll be interesting to see, like,
Wait. So your question was, how did we not notice
yes.
it? One, yeah, we fix it and dehydrate it. So we weren't aware of the significance of the artifact. But even before you get to microscopic stuff, the tradition of Western human dissection, any of us who have been around a dissecting table, what do? You open up the skin and then you take away the fascia and you throw it into a bucket under the table because it's just the glue. So the way we're taught to interact with human bodies, it's the stuff in the way, just traditional dissection techniques. You remove it. So of course you're not going to see it.
Mm-hmm. Yeah. And it seems like a lot of this finding can help explain for some of the things that we even see in conventional medicine. For instance, I've had a patient in the past with catamenial pneumothorax, where women who have basically endometrial tissue explant to the lung and pleura, and then during menstruation periods, they get pneumothorax, so on a recurrent basis. Now, so are there some things like that? To us, it was a mystery. How can endometrial tissue sort of migrate to the lung? Are there some examples of where you think that some of the mysteries could be addressed by this interstitial network?
Well, first off, everything. So we're talking about a structure that's 25% of the fluid volume of the body that has been excluded from our model making for any disease or normal functioning of the body. So what isn't going to be different than what we expected? I'm really glad you brought that point up because I had a terrible time getting through medical school. I failed second year. Pharmacology got me by 1 point and I had to repeat the whole year. So when I got to the clinical floor, I was desperate to find out I was smart. My first patient in medicine was a young woman who was coughing up blood and everyone thought she had TB. But being the medical student, I was the only one who had the time to get a full history. And it turned out she only coughed up blood when she was menstruating and she had endometriosis. That's one of the questions we have with doing the gynecologic system. Is this the pathway? There's much hand waving about how endometriosis spreads through the vascular supply, but it doesn't make sense. Could this make sense of it? I already mentioned, the structure of carcinoma spreading in breast cancer or in melanoma clearly maps to this. Necrotizing fasciitis, flesh-eating disease, where you have a skin infection and then suddenly your arm is falling off and you've got uh, meningitis and your organs are failing. How does it get around? It turns out that if you go into the literature and look at all the organisms that cause necrotizing fasciitis, by my count, 85% of them actually produce hyaluronidase. So there's something. Um, Talk to surgeons about the way they see fluid moving, and whenever they go in, they're seeing this in action. I don't think there isn't anything that isn't going to be touched by this in some fashion.
Mhm. So it seems like bacteria can produce hyaluronidase. How about cancer? Like, does cancer
Oh yeah,
cells
yeah, yeah.
also?
Oh, absolutely. And there's a lot of work being done in terms of um, uh, interfering with cancer migration through the spaces. One, identifying hyaluronidase production as an increased risk factor, so we can stain for hyaluronidase. Those tumor cells tend to do worse. We can target that. We can also uh, use hyaluronic acid bound to uh, chemo molecules, for example, to help target tissue. People are trying that sort of thing. Um, there's a guy named Peter Friedel who's particularly important in terms of cancer spread. For years, he's been saying the cancer moves in its initial phases not by digesting, which we've traditionally been taught that tumors digest, eat up the tissue and create their pathways for spread. And he was showing for well over a decade with in vivo microscopy that tumor cells move through pre-existing channels. He thought these were virtual channels that the tumor cells opened up. We quote his work in ours, and we spoke to him very quickly after publication. And he sees that, oh, they're not virtual spaces, they are these pre-existing spaces. So he's working on treatment approaches that would influence how tumor cells move through the spaces. And it's not just hyaluronidase and hyaluronic acid. There's a lot of macromolecules there to interact with. Like I said, many glycosaminoglycans and uh, the other ones, PPGs, proteoglycans.
Mhm. Yeah, yeah. It looks like we have a question in the chat. This may be an interesting question, although it's a tough question to answer. Is there a relationship between biophotons and interstitium?
I sure hope so. um, we need significantly more work about biophotons, how they change in health and disease, what their source is. We don't really, as far as I'm aware of that literature, basically we have detectors around tissue and we can see when they're produced, and how that can be modulated to some extent. Becky, we've been talking for years now. We've both been busy with other things, but we really want to build interstitium in a chip. That's something she's done. Bile ducts in a chip. You can create small bits of tissue in silica and then do all sorts of interesting experiments. And interstitium in a chip would be really cool for biophoton research, piezoelectrical stuff, as well as the hyaluronic acid spaces through them. I really do think it has a buffering capacity and a filtering capacity, that cytokines, chemokines, growth factors are limited or held in place at high concentrations by this. And that's why, for example, one way of thinking of aging is a systemic inflammatory condition. Well, another thing about aging is we lose our hyaluronic acid, which is why we have wrinkles. And every woman on this call probably knows how they're being targeted for hyaluronic acid stuff to put on your skin. Too bad it doesn't absorb through the epidermis, so it's useless. But you diminish, I think that's an interesting parallel. You diminish hyaluronic acid with aging, and systemic inflammatory conditions increase. I think there's a relationship there.
Yeah, that's amazing. And there seems to be an interesting relationship between interstitium and the immune system, like you were talking about, sort of inflammation. Like for instance, Ehlers-Danlos is sometimes associated with mast cell activation
Yeah,
syndrome. So, like,
yeah.
what are your thoughts in terms of how the interstitium and the immune system actually interacts?
Given that I have Ehlers-Danlos. Thank God, so far I don't have any mast cell problems. But that's an intriguing thing that within a week of publication, both patients and EDS clinicians asked me about that. So I didn't talk about the cell contents of the interstitium. Um, and it's really interesting. There are very few lymphocytes. It seems to be segregated from the large scale immune system during normal functioning. What you have are these lining cells, which are a kind of fibroblast. They have lipogenic, they can function as lipogenic precursors. They're immune modulating. How many types of cells and fasciocytes, as Carla Stecco talks about, how many of those cell types are there? Is there a lineage relationship between them? Are there functional relationships? That's one giant question, and obviously involved immune signaling. The other two cells are macrophages, which I already showed you with the tattoo. Makes sense. Facing what's outside, wouldn't you want macrophages at the ready? And mast cells. This is the mast cell niche. And so, oh, shocking. Collagen 3 is disturbed, and the basic structural niche of mast cells is 50% type 3 collagen. Something potentially could be going on there. And then you get lymphocyte migration through if there's injury, if there's infection, if there's cancer. But generally, it's sort of segregated. So there's a very interesting physiologic thing there too that we don't really know anything about.
Yeah, I think there's some questions coming in. Actually, I wonder if Neil, are you willing to stay like five to
Oh yeah,
10 minutes
I'm
afterwards
a
to?
pathologist. My patients aren't going to be tapping their fingers.
Okay.
As long as the
All right.
reports are done by this afternoon, I'm fine.
Okay.
So I'm happy to hang out. Yes.
Great, great. Maybe I'll ask one or two more questions and then sort of end this talk, and then just a few announcements, and then you could, for those who are interested in answering, having questions answered, maybe could stay on for another 5 to 10 minutes. There seems to be a question about chemotherapy. How does chemotherapy affect interstitium?
I don't know.
Okay.
Gotta ask. I don't know.
Yeah.
Although, again, how does interstitium change in cancer? Think of lymphedema. It's the interstitial spaces that are filling with fluid. And
Right.
it's tense because they're lined by elastin fibers, right, which are trying to contain it. And the fluid is filling. That's why it's so tense. Anyone who's ever drawn blood or nicked the skin of someone with lymphedema, interstitial fluid is oozing out. You see it. It's a clear yellow, sticky, highly proteinaceous stuff. Um, but yeah, these are we don't know. And what happens in wasting? Look at bodybuilders who are doing competition prep and dehydrating themselves. Uh, what they're doing is they're emptying their interstitial spaces through their body. Um, there's a We could study that here. It's a natural experiment or unnatural, but there'd be information we could glean.
Yeah. Yeah, there's some other questions as well. What I'm going to do is I'll just quickly do a quick ending here. Let me share my slides here. And for those who have questions, could certainly ask them afterwards. So there's a few important finance announcements. First, we hope you'll join us next month for the grand rounds with our Osher postdoctorate research fellows. Our fellows will be talking about gait, sports psychology, and physical activity in older adults and athletes. Also, please save the dates for two very exciting events that will take place later this year. First, on December 9th through 10th, we'll be hosting our next network forum centering on the theme of the intersection of high-tech medicine with soft touch healing. This will take place in person at HMS Martin Conference Center and will, as usual, be open to all for free. We have an amazing lineup of world-renowned speakers coming from academia, industry, and government. And on November 8th, our team will be partnering with a large Osher collaborative to host a virtual symposium entitled Healthy People, Healthy Planet. And you can learn more about these programs, view archived grand rounds, and even make a donation to support our work at our website, oshercenter.org. For those who have to end at this hour, thank you for joining us. And thank you, Dr. Thies, for giving such a wonderful talk and opening our eyes to this area of much needed research. For those who want to stay on to ask questions, please do so. Yeah, thank you all for joining us today.
Thanks, everybody. But I'll stick around. Yep. This is the fun part.
Yeah, this is the fun part. Do you see some of the chat? Do you see the chat?
Yeah. Yeah. So I saw someone asked about Tai Chi. Um, I think it was specifically about cancer, but um, it's a puzzle to me. So as I said, I started doing Tai Chi after I published the paper, and I thought if I have some sort of experiential thing, and I would maybe I'd better understand how this relates to Chi. Um, and it left me with far more questions than answers, unsurprisingly. Um, my teacher first talked to me about anatomy as he understood it in that language, and it sure did seem like we were talking about fascial structures and tendons and ligaments across joints, the nine pearls, etc. But he was the real deal. I mean, we could be, holding a stance, my hands up against his shoulder, and there'd be no physical mechanical sensation to me. But suddenly I thrown 30 feet back, and if there's not someone to catch me, I would hurt myself. Um, and then, um, because of my EDS, I don't have a lot of proprioceptive stuff, and I don't have an internal sense of my body. I'm now coming to understand the way a lot of people do. And we'd be there in stance, and he'd be talking to me about cultivating my chi. Um, and I would start to imagine something that might be labeled chi. And I realized it was something I could experience as a kid, and I just sort of dismissed as something weird. Um, but when I experienced it, but didn't say anything to me, because I thought it was silly to bring it up, I really wasn't confident. I would experiencing it, and he would go, "That's it." I was like, "That?" And he goes, "Yeah, now do it more." And I would work at it, and we'd be quiet for a while, and then I'd suddenly feel like I could amp it up. And again, there was no positional mechanical thing going on here. It was an internal sense. And he would report back, "Yeah, that's it." So, but really, could piezoelectricity alone be sufficient to explain being thrown across the room? Or, flames coming out of your hands, or electrical, I'm working with some people at Tibet House to look into this stuff with some adepts from India who can do those kinds of things. So it's related, but
Yeah, I'd love to hear what Peter has to say about this, but yeah, this is an area certainly that is fascinating and probably worth exploring. And the fact that you're actually feeling this energy, Neil, may relate to a question that is asked here, like how does the interstitium relate to the peripheral nervous system, the central nervous system? Like the fact that you're actually feeling something may imply that there's some kind of nervous interaction with the interstitium, right?
yeah, well, of course there is. There has to be. Everything's connected. There are no boundaries. Um, but I don't know. um, what I know is that how this is having those experiences, what happens when I bring my focused awareness during, I'm a Zen student too, um, and in meditation, we talk about in Zen practice, we talk about jiriki, that after an extended retreat, you often are just sort of bursting at the seams with, try and get me to stop talking. And this is what my baseline is like after a week meditating. I'm like, eh. Um, but now that I've had these experiences and have this understanding, there seems to be something, there's a subtle relationship here. It's not just I feel energetic.
Yeah.
Part of the problem, as everyone in this room knows, we don't have enough words for the kinds of energy we're talking about. English is impoverished for such things. And how this relates to consciousness itself becomes, that's the book. um,
Yeah.
and I'm happy to talk about that sometime, but
Yeah.
that's a whole other session.
Well, it's
Either
hard to not add, jump in. Can I comment on this, Andrew? And it's
Yeah.
just, first of all, this is just such rich material, and thank you. Thank you for the work, but also your ability to hold a larger space to start to think across these paradigms. But in terms of your Tai Chi, just because that's something I spent some time thinking about, I think even before you get to this magical level, there's got to be pieces of what you're talking about where you're just the biomechanical piece of knowing that this whole system is implicated, it's connected structurally, like Helen's work has done. And then the hydraulics within that have tremendous force. And then, as you said, in meditation, the coherence of the lack of distraction, allowing you to feel the wholeness of the system and to steward it to something. And then maybe superimposed on all of that, some neural charge that makes this like a hydroelectric system. But I think there's just so many hypotheses. But those of us who practice this, we feel things, and you're creating this heuristic map, as you said, a metaphorical map, but also a very biological potential bridge. So just thank you. It's just
Sure.
you're at the edge, and when you bring things together, that's where we learn, and that's the heart of Taoism. So
Yeah, I of spiritual practice in general. No, I thank you. I really appreciate that. One of the fun things about this, and as I said before we started to you and Andrew, the interstitium stuff is headed in this direction, but all the work I do in complexity theory, and the nature of boundaries across scales, etc., which then gets into the consciousness stuff, they're all sort of at the same edge. Um, and and I get to hang out with really cool people who enjoy being at those edges, and things are starting to happen as a result of that. The best interdisciplinary work is starts with people who are willing to listen to each other and learn each other's languages, and I'm getting to participate in that every time I show up somewhere. So thank
Yeah.
you.
Yeah, it's amazing the openness now that we see to these novel ideas. And I think we're kind of at this new area where people are a little more open to finding out a little bit more and asking questions that wouldn't have been asked before.
Yeah.
It's really great. And in the interstitium, I mean, there's so many things that's underexplored. Like, for instance, the nerve innervation of connective tissue is underexplored. Like, Ruffini endings are a type of nerve receptors that wrap around collagen. Like, what their roles aren't entirely clear.
Right.
There's, as you say, sort of the electromagnetic aspects of connective tissue, because hyaluronic acid is highly negatively charged, and if you have fluid or plasma move through it, you have something called streaming currents. Also,
Right.
if you have an electrical field that happens there, then you actually cause fluid to flow through that rich electrical matrix. That has not been fully explored. And collagen itself, as you say, is, piezoelectric. It's also pyroelectric. So if you apply heat to it, which, it also induces charge. It could explain for why people are using moxa or heat. There's also interactions with light with collagen, because collagen is crystalline. So that's how you get the second harmonic imaging, is that you get two
Right, of
photons of the same
Of
energy.
course, right.
Right?
Oh, duh. Two photon imaging. You want biophotons?
It,
Sorry.
I mean, there's a whole area so rich to be unexplored, and I feel like we haven't even touched parts of this yet. And I think,
There's a bunch of I'm seeing some other stuff pop up in the uh so cancer patients doing Tai Chi. Um, I get asked this kind of thing a lot. I think that some sort of holistic practice like Tai Chi, for example, or Qi Kong could be very helpful, though we're still making an assumption that um, increasing energy levels, whatever we mean by that, is that going to be useful to cancer cells, or is it going to be useful for restoring homeostasis and unhelpful to cancer cells? And there's a bunch of work, and this is sort of the stuff that Jason Yantopoulos, which is how I know Andrew, is heading up research programs where they're looking at, cancer cells react differently than normal cells, and so that may be a way of distinguishing them. But I've been stuck in the middle of public discussions at the World Fascia Congress of, doing massage of a tumor, isn't that going to be helpful? You're opening up the interstitial channels to get immune, but you're also, Peter raises the point, but you're also pushing tumor cells to migrate. And he's actually done an experiment using mechanical stuff in mice with a tumor, and helps them migrate. So I think we have to be very careful about intuitive leaping and thinking about things. This is where I'm very cautious about metaphorical stuff, how we apply them. So, but I would think that Tai Chi or Qi Kung, just, or meditation of various kinds. I mean, they're anything that brings the body into homeostasis. Cancer is an example. This gets into a complexity theory thing. Cancer is an upsetting of the negative feedback loops, or an overabundance of positive feedback loops of the body as a living complex system. And any practice that helps restore the negative feedback loops, which accomplish homeostasis, are going to have the potential to help in a disease state. And I can tell you some, I've got anecdotal stories of long-term meditators in cancer that will knock your socks off. So I think that, but ultimately all of these things, even if it's not going to cure you, it's going to help you live until you die, probably in a richer, more adaptive fashion. So maybe you're not going to live longer, but you're going to die better. I think that's probably true too.
And I wonder if this is a place to just, building on what Neil is saying about metastases, that some of the work you probably have seen, Neil, that Helena's done recently, showing that there's a sort of a dosing. There's certain types of mechanical stretching of tissues in animal models with cancer, where you can change the growth of tumors and their probability of metastasizing. So just these mechanical forces associated with yogic and Tai Chi like movements. And it may be that very abrupt, abrasive movements are not so therapeutic and being stagnant, but like everything else that's rich in biology, there may be that in-between rhythm. And maybe that's what these practices have sort of intuitively found, that dosing of mechanical forces and integration is where the preservation and healing happen.
And the promotion of homeostatic feedbacks in the body, which are always oscillating around a comfort zone, a healthy region. Something else I wanted to say. So Becky has published a paper on this. One of her biomechanical things is thinking of collagen, how collagen forms fibrous networks, which aren't just simply the way I've been talking about it. There are networks of collagen, which are fascia. A fibrous network has very distinct properties for transmitting signal over long distances. So it's not just hydraulic effects you were talking about, the mechanical aspects of this, but there's long-term signaling across fibrous networks. And what they did was they varied the amount of hyaluronic acid, and it turns out hyaluronic acid dampens that. So a healthy amount of hyaluronic acid diminishes the signaling capacity of the fascia as a fibrous network. So
Interesting.
Right. So I mean, the complexities here metaphorically, not as a complex system, the complicated nature of what we're working with. But I used to, when I was much younger, I used to think like, well, how did they figure out acupuncture? Did they just like stick a needle until they got an effect? And someone, a whole bunch of people mapped out. it took me a while to understand, maybe because I was missing it because of the Ehlers-Danlos. No, people have direct perceptive capacities of their own internal states, of other people's states, or of the state of a merged system when two beings come in and their complex fields across scales are becoming a single field. That the kind of awareness that allows us to see these things, that's a big piece of what we've been missing. It's what Francisco Varela talked about, second person um, perspectives. There's first person, I'm reporting me, there's empirical science, I'm looking at you as an object and we're separate. But then there's a second person perspective which arises between those. And it's what happens between my Tai Chi teacher and me, and him helping me identify that experience of something, or mind-to-mind transmission in meditation practice. That's something we're missing in our culture of research. That I think is
Agreed.
important.
Yeah, it seems like, I mean, there seems to be so much interest in, I have never seen 100 people still stay on Zoom
Of course.
after 15 minutes. So this is amazing. Maybe I could open up the forum to people who want to raise their hands and
Yeah,
then
just
ask a question.
let's do that.
Yeah. And the problem is that I can't see who's raised their hands because there's too many screens. So
People just unmute themselves. If
yeah,
they
just mute.
Yeah. I see one. Is there an interstitial connection linking scalp, trunk, foot? Yeah, because everything is a single network. Go back to that layering of, there's no part of the body that's separate from any other part of the body, period.
Yeah.
But
Elisa
the
has,
mapping of it is tricky because it's really complex.
yeah.
Yeah, Alyssa.
Yeah.
Oh, Alyssa.
Hi.
I know you.
Yes, you know me. So you talk about things on scale, and nature has a tendency to repeat, especially when something is very good, it's preserved and it's repeated. So what you're seeing, is this also what Galen talked about regarding the rete mirabellum, the wonderful network, blood vessels and nerves bound together by fibrous tissue, and you're seeing it on a smaller scale.
Well, and the fibrous tissue that binds it across all scales is that, right? Again, but Galen was a traditional anatomist. What did he do? He threw away. If he wanted to see the nerves and the vessels, he got rid of the connective tissue and would report, oh, it's bound by this connective tissue, but he treated it like inert glue, not as a. But now imagine you have. So yeah, I mean, we're talking about the same thing, and yes, across. We know that the vascular network is a fractal network. I don't know if nerves are, technically speaking, a fractal network. We don't know. No one's done the math to tell whether interstitium is. But think about any structure in the body where you've got arteries and or veins with a nerve, and they're linked by connective tissue. That's a single interstitial channel interweaving between them. The artery has a pulse, so is driving a fluid wave through that,
Right.
which is then
So
propagated.
right.
Now, the nerve has an electrical current through it. So isn't it creating motion in the collagen fibrils of the perineurium, and how far out does that propagate? Now, how do all of those things interweave together? And then put that neurovascular bundle with its connective tissue, adventitial fascial sheath in the thoracic cavity. The diaphragm's going up and down. So there's another high pressure, low pressure system. And then put it in the thoracic cavity near the esophagus. And every time you swallow, you're creating another pressure wave.
And all the motility in the gut as well.
And then go into full arm balance and turn it upside down.
I'm sorry I'm interrupting, but
No,
when you
please,
talk about the network of the nerves, Gil Hedley dissected all the nerves from the whole body. And he's going on the nerve tour to talk about how these nerves interact and
Right.
well, interconnect.
Right. But they're interconnected with the fascial connective tissue around them and the interstitial. It's all a weave. And at the nanoscopic level, it's just molecules floating in fluid. There are no cells, there are no vessels, there are no nerves, there are no anatomic structures. It's molecules self-organizing themselves in space, in fluid, which is at body temperature, which gives it a certain kinetic energy, which is what this is chapter 4 of the book, I think, or 5. And the physiology of the molecules of our body that create these larger scale structures, it's not dependent on food as energy, it's dependent on the kinetic energy of your body at normal human body temperature, part of which is maintained by what you eat, but not entirely. So, at the molecular level, none of this stuff, we have to leave all of those things behind. We're dealing with molecules floating in aqueous solution at a certain temperature and the kinetic energy there. But then you come back up.
Thank you for your work.
Thank you.
Neil, looks like there's a question. Louise, do you want to ask the question?
Yes, I wish you were here to sign a copy of your book. I want to apologize. I also want to apologize for having my camera on earlier when it should have been off. And I wanted to say I've been interested in interoception. I come at this interest from my Tai Chi lifetime practice of Tai Chi. I'm a yoga teacher, and I also practice self-myofascial release work. And I find that there might be a connection between our more current understanding of interoception that's evolved from just visceral signals to a much whole body sense of itself. And I'm wondering if you agree that fascia and interstitium might be sort of our pathways for interoception, and how enhancing those, having healthy fascia and interoceptive ability, might bring us towards this whole being, whole health that is the sort of opposite of where we're at for a lot of.
No, I mean, it has to. And there's a terminology problem here, and I've sort of danced around it, and we're all sort of having a problem talking about it, interstitium / fascia / whatever. So I'm just going to give you a preview. Carla and Antonio Stecco, Robert Schleip, Hélène Langevin, Rebecca Pratt, Lori Nemitz, and me have been talking monthly for about 2 years now. And we've got a manuscript we're finishing up, and we're going to be able to submit, we think, in a month or so, but we will post it on bioRxiv. What we think is that a useful terminology would be to call the collagen networks of the body a fascial system. The spaces within it are the fascial interstitium. The fascial interstitium is in continuity with 3 scales of interstitium: cellular, intercellular, pericapillary, and fascial. And that's all one network. There are no boundaries between any of these. Every organ system in the body is defined by one set of primary functions, even though there may be many functions. And we're saying that the fascial system's primary descriptor is that it accomplishes tensional loading and shear mobility. That leaves out the question of the communication network. And clearly tensional loading and shear mobility are not something anyone can argue with. So that's a primary definition. But is it really primary? One of the things I've been thinking lately, the last few months, I've been wondering, should we have known there was an interstitium to look for, or a fascia / interstitium? Should we have known that it was going to be there? And when you think about this, the body-wide communication networks, we've got the nervous system and we've got the cardiovascular system primarily. The cardiovascular system has mechanical properties, but it's primarily fluid flow and molecular and cellular movement. The nervous system, primarily electromagnetic. But the fascial interstitium system signals across every level of scale, nothing left out. So the fact that we were settled into these two limited body-wide signaling networks as being sufficient to explain everything, without thinking there must be a system or a complex of systems that in fact could communicate across every scale we could think of. And this supplies that. I don't remember what your comment or question was, but I thought I should talk about the new nomenclature. But so I'm sorry.
No, it's a very, very wonderful clarification. I look forward to looking for that paper. And I was connecting it to interoception.
Right.
Which
the thing I'm missing, it's so interesting to me because I'm only just starting to realize, oh, that's a thing I'm missing, probably because of the Ehlers-Danlos. So it's hard for me to comment.
Because that's, to me, the interoception is what helps us dial into the homeostasis.
Right.
And so we have a sense that tells us how to do that. And so it's a sense that was greatly disregarded, just like fascia and interstitium. And I'm wondering if they're connected somehow. Is that
they have to be.
Sense?
They have to be. But if fascia interstitium is a body-wide communication network across all scales, then it's how the body perceives itself, which is interoception.
Right. Okay. Thank you.
Yeah.
Period.
Yeah. And actually, the mechanisms by which, so my understanding in terms of interoception is that it's largely based on free nerve endings, because there are different types of nerve receptors. There's mechanoreceptors and, specialized receptors, but free nerve endings are the ones that are sort of natively like naked exposures of the nerves to the environment. And they're the ones that are importantly mediating interoception. And that's why vagus nerves, for instance, they have free nerve endings. And then the other pathways, the spinal thalamic pathway, which also have free nerve endings. These free nerve endings have a lot of very interesting receptors. And they're the ones that seem to penetrate all parts of the body, and the interstitium particularly. And I think this is the part that we haven't really explored sufficiently, because it seems like it may actually be even in the perineurium itself, or even the perivascular areas. So they're sensing a lot of things. And actually, I wanted to quickly show you an image. If you can see here, is these are all the types of receptors that you get from the free nerve endings. And this blew me away, is that you could sense all these different aspects, inflammation being one of them, serotonin, ions, bradykinin. I mean, the types of receptions that you get on these free nerve endings are endless. So it just gives you a sense of the complexity of interoception, and even the pathways that's involved in it. Sorry, I didn't mean to.
Yeah, I was just gonna add to that Michael Turvey had talked about the whole fascial system as an organ of perception. And so I think that goes to the previous speaker's comment and what you're showing, Andrew, and what Neil's talking about.
And there are people who speak to me who have so people who are doing shamanic practices where they're able to explore the world using their minds and encounter non-material realms of existence and non-material consciousness. And some of those have been shared with me briefly enough to make me think, oh, and this may be book number 2. People who both are fascia workers and have those capacities or skills tell me they're related to each other. They don't know how to explain it. I don't know how to think about it, but there is that intuition out there from people who have those abilities. And so, yeah, that's another layer. That's not as weird and woo-woo as I get, but we're getting close to the edge.
May I ask a question?
Please, yes.
Yeah, back about 50 years ago, I read a book by Ramurti Mishra, MD, an endocrinologist who was also a yogi.
Mhm.
And in this book, he had diagrams where he superimposed the chakras on every system of the body in medical terms. And I'm just wondering whether you have any reflections on, have you read this and have you any reflections on that regarding the interstitium?
No, I haven't read it. The only curiosity, and again, this is not something I have a very strong sense of. I've tried to be trained for this. It's not something I'm good at, but I have to wonder, you've got this large scale electromagnetic system in the body that is necessarily creating a complex, three-dimensional in space and four-dimensional because it evolves over time with movement and states of being, a bioelectromagnetic field that must have structure. I don't know what the structure is, but it must have structure. And then you have the chakra system, which looks like a structure. To me, that's an obvious question. I think we have people who are skilled at reporting those structures and the physical experience of those structures. Maybe people in this room have technology that can do that, but I think to answer these questions with precision, those are the kind of things we have to develop. But that's my best, that's the only thing from my experience that I might suggest.
Thank you very much, Dr. Theise. This is wonderful. This is a wonderful talk.
Thank you. Thank you so
Thank
much.
you for your work.
I'm just aware of time. I realize that we could probably spend a few hours talking to each other and then still
Bring me to
people have, still have like 90 people.
I'll be in Boston at the end of September, middle of September, for Deepak Chopra has his Sages and Scientists conference. So maybe that's an opportunity I could actually visit and hang out. That could be cool.
Yeah. When is that? Mid-December?
Mid-September.
Oh, mid-September.
Yeah.
Okay.
Yeah, let's talk offline. It'd be wonderful to connect and share a meal and go a little deeper into this.
Sure.
And I don't know, Peter, how would you suggest? There are also a lot of questions here. And
I think it's exponential here. I think maybe we can just think of these as we've seeded these networks of thinking and collaborating, and let's let them stew for a while. And I don't think we need to methodically and reductionistically get to every one of them. So that frees Neil from any post talk work. So
well, and I think you've gotten a sense of how if you ask me something I don't know the answer to, you've gotten a sense of how I try to figure out an answer. And for this, I really do start with just what's the structure, and then where does my imagination take me. The most important slides, I think, in the talk are those ones where I try to show you what does the 3D thing look like. Now, the best way to do that, and I've done this with audiences, I show them the images and then I have them close their eyes and introspect. Imagine your own cardiovascular system, imagine your own nervous system, et cetera, et cetera, et cetera. Many of you have great capacities in this range. So use this, pretend that was a guided meditation thing and look in and see what comes to mind. I'll make you bet you come up with some good stuff.
That's great. Well, thank you so much, Neil, for an outstanding discussion. You could see clearly there's a yearning for this type of topic, and you're really opening it up. Hopefully there are opportunities for us to meet and have this discussion carry forward. This is just the beginning. I think this is some really cool stuff. So thank you so much, Neil.
Thank you so much, everybody.
Yep.
Bye-bye.